My name's Dr. Ronald Chaney. I'm a staff internist in the General Internal Medicine Department at Gundersen Lutheran, and I've been functioning here for 20 years. We deal with two types of patients that care coordination is intimately involved, and that is, one is the elderly that has multi-system organ involvement of their disease. They're frequently on many medications, and they have multiple appointments, multiple visits to the healthcare facility. Since care coordination has become involved, they serve to coordinate the care in transitioning from, say, a discharge from the hospital to the outpatient setting or into a nursing home. They attend all the appointments, multiple subspecialty appointments. So when I see them in the General Internal Medicine Department, they can often give me updates as to what has happened in the subspecialty clinics. The big difference in having care coordination versus not having care coordination is the patient's ability to get appropriate services in the medical system. Without care coordination, the patient often ends up in the emergency room or in an urgent care setting because they are always having symptoms and they get very anxious and they don't know where to turn to. With care coordination, they can just make one phone call to one person and get a result.
My name is Dr. Kerry Jedele. I am a geneticist and I also take care of medically complex children. The benefits of having care coordination are just enormous. The patients that I take care of typically have multi-system involvement, meaning they're seeing many different specialists across various areas of the clinic. Obviously, we can't be with them all the time and we don't always hear all the details from our colleagues. The care coordination nurses go along to these various appointments. Not only do they pass on medical information, but they have a chance in between times to chat with families and to scope out the situation, get a sense of what's really bothering the families. They often get wonderful social information that helps us tremendously in terms of being able to care effectively for the families. The families that have the care coordination will come in and have several appointments on the same day. They will have someone walking them from one appointment to the next. They know that the information that is passed on through one medical provider will be discussed with all the other providers so that all of us can agree on a comprehensive medical plan and not be sending out mixed messages to the family. Again, these families have many providers and very difficult, complex problems, so it's very easy for different providers to have different opinions. That's not all bad, but we need to make sure at the end of the day that we're all on the same track. And care coordination does a wonderful job of holding us to that standard, of making sure that we all talk to each other or pass on messages, that we're not sending conflicting messages to the family, and that if any of these conflicting messages do come up, that they're resolved in a very good way that makes the families feel like everything's being done in a constructive, helpful way that is centered on their child.
I'm Becky, a care coordination social worker at Gundersen. In 2010, Crystal, a 41-year-old single mother of 3, was involved in a car accident that left her quadriplegic and cognitively intact. After a prolonged hospitalization at another institution, she was discharged home and developed a stage 4 sacral wound and sepsis. She was then admitted to Gundersen, where she was enrolled in the care coordination program because of the medical and psychosocial complexity of her case. Crystal was in a self-directed Medicaid program that allowed support system personnel to provide at-home care assisted by home health staff. However, Crystal's personal support system fell apart. She and her significant other, who had been her primary caregiver, ended their relationship. One of her children left home for college, another adult child could not assist with Crystal's care, and our youngest child, still a minor, was staying with relatives because Crystal could not care for her adequately on her own. All the while, Crystal's wound was not healing. Given these circumstances, Crystal reluctantly agreed to short-term placement in a nursing home far from friends and family in another county, one of the very few facilities that could address her needs. Crystal feared that this arrangement would become permanent and that she would lose her eligibility for funding for at-home support personnel if she ever did return home. The care coordination team contacted various state agencies and with much effort obtained permission for Crystal to maintain eligibility for at-home support while she temporarily received care in another county. Crystal improved greatly at the nursing home and desired to return home even though her wound was not fully healed. The care coordination team members felt this was attainable with an enhanced infrastructure of support. They obtained for Crystal additional in-home services for personal and supportive care, supplemental durable medical equipment, and in-depth education on skin and wound care for the in-home staff. Crystal's needs are being managed on an outpatient basis. The care coordination team continues to coordinate care with multiple agencies and all of Crystal's providers. She has had no unplanned hospitalizations and has not needed to return to the nursing home. Her youngest child has moved back in with her. Crystal calls the care coordination staff her guardian angels, saying she would not be where she is today without them.
My name is Deb, and I am a registered nurse in care coordination at Gundersen Lutheran. I would like to share a story about a patient we cared for. Ethel was 94 years old, had lost her husband, and had no other close relatives. Her primary provider, who observed that the once vivacious, independent woman was experiencing various medical and social problems, referred her to Gundersen's care coordination program. The assigned care coordination RN, who quickly developed a bond with Ethel, noted that Ethel had a declining quality of life, was losing weight, and had become completely chair-bound and dependent on home care. One day, the care coordination nurse asked Ethel what she really wanted. To the nurse's surprise, Ethel bluntly replied, "I want a dog." After talking with Ethel more during the next few weeks and consulting with various personnel, the nurse came to see that a dog might just be what Ethel needed. She searched ads for a suitable animal and eventually obtained one for Ethel, who was overjoyed. Ethel named the dog Baby, and Baby has given her new life. Ethel went from being chair-bound and dependent to walking up to 125 feet and playing the violin for visitors who come through Gundersen's lobby.
The patients described in this video have given written permission to Mayo Clinic Proceedings to share their stories with viewers.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.